and I'm going to talk about phenotypes and the whole idea that we've got to move beyond talking about sinus disease as polyps and no polyps. Now, I apologize if, it's something I love talking about. I was involved in the EPOS 2020 group that tried to propose a new classification system. So if you've heard elements of this before, I apologize. No, there are my disclosures, none of which I think really affect the content here. So a big question I want to talk about, how do we classify? We call it CRS. But when we say CRS, there's so many different conditions that are called CRS. I now believe that, this idea of just calling it CRS, it's so ambiguous. We mustn't use this term, in my opinion. I would say that chronic rhinosinusitis is as term as ambiguous as asthma. And I would even say that nasal polyps is a term as ambiguous as asthma, so even the term polyps doesn't really describe what's going on. And I think, unfortunately, it's left a generation of people not really understanding sinus disease. And they don't really understand the causes of it. Well, this is not true. We know a lot about sinus disease, and it's not just some heterogeneous group. There are very, very distinct phenotypes and disease processes. And I can tell you in Sydney, when trainees or fellows come to Sydney, they are never allowed to call a patient a diagnosis as CRS. They have to tell us what is happening in the patient to create that situation. But if you look at texts and studies that are done, let me just start my timer here so I don't go over. So if you look at textbooks, they often present these sort of images to someone learning about CRS. And I feel so sorry for our trainees who are given this. This is rubbish. There's everything there possible. The only thing that is not on the list here is what I ate for Sunday brunch. So having this generic thing where everything can cause CRS doesn't help people translate any sort of treatment or management strategy. This is the biggest problem. And you know what? In over the years, I've seen very scientifically unsound constraints applied because we're not really making it clear as to what's going on. So sometimes, like in Australia and the US, you don't get your surgery unless you've used a nasal steroid spray. But the problem is that the disease ain't in the nasal passage, it's in the sinuses. Sometimes you have to have antibiotics before you get surgery. But we know, especially in polypoid conditions, it's not an infective process. So we're forcing our patients to have things done in order to get their next level of care. That makes no sense. And even this one is even more ludicrous. So in some parts of the US, unless the CT scan on the day of the scan shows disease in a sinus cavity, they can't operate on bill for it at the time of surgery. This is like listening to someone's wheeze in their lungs and approving a puffer for the right upper lobe because that's where the wheezes were heard, and you're not allowed to treat the rest of the lung. So there's very unscientifically found constraints. Now, people have tried to sort this out. They've tried hard, but people who still work with the CRS and CRS with polyps framework struggle. Now, this was a really nice publication where they tried to talk about it, right? They said, well, maybe CRS with polyps is a group inside CRS. But look at all the different conditions here. They say PCD. Well, PCD sometimes has polyps. Cystic fibrosis have polyps. Oh, there's some very polypoid conditions. Well, I can tell you now that, unilateral OMC surgery, sometimes that can even have polyps, and sometimes eosinophilic disease doesn't have polyps. So we really need to move away from this. And I just want to go back to this slide. Can I just point out to anyone who has experience seeing patients that on this one slide, there is cystic fibrosis, AFS, PCD, and eosinophilic disease. That if as a patient sitting in front of you, they are so different as people, so different as people. So they are such different patients, yet somehow on our classification system, they all overlap. And that should tell you something about the limitations of this phenotyping. So we really need to move away from the idea of calling it polyps and non-polyps. And let me take you through, when I worked with Witzker and Valerie, I have to give them a big shout out here because they did a great job with EPOS 2020 at trying to address this. And I'm going to take you through what was proposed, and then we'll talk about it a bit more, a couple of unique ones. So we call CRS primary CRS when it's not related to something else. So you've just got an airway condition. Now, if you have cystic fibrosis, your disease is cystic fibrosis. It's not CRS. You have cystic fibrosis, and cystic fibrosis affects the sinuses, the lungs, the pancreas. It affects fertility. It's a whole lot of different end organs. And so that's secondary CRS. If you have a combined variable immune deficiency, that is your condition, not CRS. You have CVID. So we call those other conditions, and I would say even things like odontogenic. So you've got a tooth infection and your sinus is involved. That's not CRS. That's a dental infection, and the sinus is secondarily involved. This is primary CRS. The first layer of classification then is just the anatomical distribution. This is really, really important because really sinus disease comes in two flavors. It's either localized, meaning it just is confined to one area. Now, we all know that there are anatomical areas in the sinus cavity. The frontal, the maxilla, and the anterior ethmoid drain through the middle meatus. The posterior ethmoid drains through the superior meatus, and the sphenoid drains through the sphenoethmoidal recess. So you can have disease just in that area. And if you have it just in that area, or one of those functional units, we call it localized. Or it can be diffuse. Now, diffuse disease doesn't mean pansinusitis. It just means that multiple areas are involved and it's not following one functional area. And then the second thing is just to say, is it type 2 dominant? So is the inflammation going on? Is it eosinophilic, sometimes referred to as Th2, or a type 2 inflammation? And then right now in this classification system, we just called everything else non-type 2. Now, non-type 2 may become many, type 1, type 3. Look, there may be different categorizations in the future. But in the world right now, the most research is done around eosinophilic or type 2. And this is actually where biologics and other new, commercially available treatments are situated. And so this is it. It's really to say, is it secondary or primary? Is it local or diffuse? And is it type 2, non-type 2? This is it. So you can say someone's got a primary localized type 2 condition. And an example here would be AFRS. So allergic fungal rhinosinusitis can affect just one functional unit as a hypersensitivity to fungal mucin. It often leaves behind a completely normal sinus cavity otherwise, and you can just have one functional unit involved. Now, that's important because in this situation, whether you believe it's a IgE-mediated disease or not, it's still a localized thing for many patients. Non-type 2 disease is your classic osteal occlusion. So these are patients who just have a purulent infection, as you can see on the endoscopy in the left, and they just get an isolated blockage or loss of mucosillary clearance from one sinus grouping. And that's it. That's maybe old school ideas about osteal occlusion. So we do see that to me is not the challenge of our world right now. This is easy to treat. Now, but it gets more interesting when we talk about the diffuse group. So the type 2 diffuse group includes CCAD, which is this allergic variant of polyps that we're going to talk about in a moment. ECRS, which is your classic adult onset nasal polyposis and is essentially the upper airway equivalent of adult onset asthma or severe eosinophilic asthma. And then look, AFRS has been included here because as AFRS expands and it gets bigger and bigger, you get other sinuses recruited. Finally, there is diffuse non-type 2 disease. We don't understand this group entirely, but they are patients who sometimes have polyps. They often don't have the eosinophilic mucus. You know, we talk about low or non-eosinophilic sinus disease, and it may be more prevalent in some parts of Southeast Asia. You know, in Australia, I have, 30 or 40% of my patients are Asian. You know, I still see eosinophilic disease as a prominent thing, but these patients don't respond to corticosteroid. They tend to be older, and there's other treatments for them, and I'm going to talk about this group. Now, it's really important. I'll touch on secondary CRS. I'll do this for completeness sake, but we break it into localized and diffuse. But localized is about local pathology. So things like having odontogenic disease, you've got a tooth infection and you've got sinus disease. You don't really have CRS. You've got a tooth infection and your sinus is secondarily involved. You can have a fungal ball. Now, whether the fungus is there as the main problem or whether it's secondary to a sinus cavity that's not working, I mean, that's still for debate, but that's an example of a secondary CRS. And you can have a tumor. So this person's clearly got a lot of inflammation in their maxillary sinus, but their main problem is they've got a big papilloma in their ethmoid. So we don't really call this CRS. We call this a tumor with some secondary CRS. Now, for the diffuse group, though, this is really about secondary disorders. So people who have mechanical problems, such as primary ciliary dyskinesia or cystic fibrosis, these are mechanical or mucosillary disorders that affect the entire body, so secondary CRS, but it's diffuse because it's a body-wide problem. There's an inflammatory group, things like vagueness or granulomatosis polyangiitis, as it's now called, is a great example. Yes, the sinuses get involved, but so do the liver and the lungs and other parts. And then, of course, we have immune problems. Some people have selective IgA deficiency, CVID, you know, they end up getting flares in one sinus and then the other, and they come and go. But their problem really isn't CRS. Their problem is a immune deficiency. Now, why is it important? So this is the figure from EPOS. It's really important because if you have localized disease and you're trying to teach someone how to manage it, when it's localized, surgery is going to play a role very early on. So the minute your sinus disease is localized into one area, unless you're just lucky to break it, I mean, AFRS should never be given medical therapy. It should be straight to surgery. And a lot of isolated sinusitis from osteal occlusion could maybe be resolved with medical treatment. But if it doesn't resolve with simple medical treatment or well-directed cultured antibiotics, then really most people go on and have surgery, and it's curative. And so for most of these patients, a cure is obtained. But the bottom pathway, where it's diffuse, this is not a surgical disease. It's not a mechanical blockage. It's not a ventilation problem. And it's not something that surgery is going to cure. So the ENT surgeon needs to have a very good framework as to why you're operating here. And this is this patient. And, you know, to me, I still think patients with primary diffuse disease or patchy diffuse disease is really a more common patient. Now, we discuss at the moment, I think in many countries around the world, the idea that somehow you have medical treatment and then surgery for failures. This doesn't really make much sense pathophysiologic, because I said to you that then makes a situation where insurance companies force people to have medical treatment. And when we did a study with Dr. Bagley many years ago, Campbell Bagley, although many people who had medical therapy with diffuse CRS, 50% were still symptomatic at the end. And although some patients felt much better, almost to the point of being asymptomatic, if their CT scan at the end of maximal medical therapy still had disease, they just became symptomatic again later on down the track. So the idea of maximally medically treating a diffuse patient and then using that as a reason to then go on to have surgery doesn't make sense for many patients. It's not as if the surgery is going to cure them. It has to have a goal for them. Now, our colleagues in Europe have tried very hard to define, what is the endotypes available. You can see here that their Galen study really came down to this idea that it's IL-5 positive or negative. And really, this has been broken down to type 2 and non-type 2. And this is why then, when you look at the classification system, it talks about diffuse disease being type 2 or non-type 2. It really comes from that sort of research. Now, I'm going to talk to you about the type 2 groups. Now, the first one here is type 2 dominant CRS, because it's a patient group dominated by eosinophils. It's not related to ventilation or drainage. It's not an infective process. They often have broader involvement of their airway, and they usually respond to corticosteroids. And in order to discuss some of these phenotypes, and look, some people here may know these well, but I'm going to use Sally Wenzel's publication on asthma phenotypes. She published this 10 years ago. I still love referring to it because it talks about in the respiratory or the lung, these very well-described phenotypes. And it's about the age of onset from childhood to adult and the severity. And here we have now, we're going to talk about this type 2 group, which is predominantly when you're younger. And the first group are the patients who come and say to you, "Oh, doctor, I've had sinus my whole life." And you look in their nose and they have this middle turbinate head edema or polypoid change coming off the central structures of the nose. When you see this in a sinus patient, they don't have polyps. They don't really even have sinus disease. What they've got is inhalant allergy. And when that gets bad, after they present at 30 years of age, their sinus cavity sometimes looks like this. They get all this central thickening where the uncinate, the middle turbinate, and even some of the glandular hyperplasia in the olfactory cleft, and they get this black halo sign. Now, down the bottom radiology, you have to understand that, of course, as your tissues thicken up, eventually you start to get some mucus trapping in the maxillary sinus. But predominantly, this person's soft tissue changes are just in the center part of the nose. Now, one of my fellows sent me this radiology picture on the left-hand side. It's not the same patient on the right, but you can see this jelly-like edema. When you get this jelly-like edema happening in the nose, and there's a bit of cobblestoning there as well, your CT scan looks like this young 19-year-old girl who was sent to my fellow when he went back to the US with sinusitis. But this is not sinusitis. When you look at this, just the center part of the nose is thickened. And if you look in her nose with an endoscopy, it looks like the video on the right. And it's not sinusitis, it's an inhalant allergy. And Valerie Lund really coined this look. She called it the black halo sign. And she said to that, I showed her some of these videos when we first started talking about CCAD, and she said, that's the black halo sign. I've published on that. And I couldn't find a scientific publication, but sure enough, she actually did talk about this. And she even put a classic case of CCAD on her textbook. And she talked about the black halo sign where just the center part of the nose thickens up. Now, sometimes it can be terrible. This patient was sent to me, grade 3 polyps, Richard, might need biologics, all sorts of other things going on. But look at the polyp. The polyp is actually just coming from the middle turbinate. You know, I'd even like you to go back and have a look here. I'm going to play it again. Look how the polyp's pushing in to the maxillary sinus opening. Look at that. It's about to plug it. See there? And so people do get maxillary trapping and they get a bit of barotrauma. But what you can't do here, just simply operating on these patients doesn't solve their problem, because their problem is inhalant allergy. Here is a patient of mine who had barotrauma. He never had his allergy treatment, despite me telling him, starting him on it. And he came back 8 years later and he said, look, I'm congested again. look at his sinus cavity. Sinus cavity was done by me 8 years previously. And look what's happened in the 8 years since without changing his allergy. The center tissues of his nose have just become thickened again. And look in his sinus cavity. There's nothing wrong with the sinus cavity. So this, and he's super symptomatic again. And so these patients, in my opinion, who get tissue remodeling, these make great candidates for oral immunotherapy. So immunotherapy and allergy treatments are required. You cannot, in my opinion, nasonex this condition away to suppress it. Simply using nasal corticosteroid sprays are not enough. You really need to take a different approach, and this is where immunotherapy lies. So in my first phenotype that I'm going to describe, it is really the patients whose underlying condition is an exuberant allergy, and this is what is CCAD. And treatments here can include simple sprays, immunotherapy, and this is where actually maybe omalizumab as an anti-IgE agent may have a role. The next group is this equivalent of that little red circle up the top there for the asthma patients. It's this very severe adult onset condition, which comes on often between the ages of 30 and 50, and they have severe polyposis. Their scans look like this, and you look at their middle meatus, they've lost their smell, the asthma is bad, they're very congested. This is true eosinophilic CRS. And these patients have a real problem because their inflammation is not here in the nasal passage. It's out here in the sinus cavity. And they have a real problem getting medicine. If you give eosinophilic or ECRS patients prednisone, they love it because they get the medicine into the sinus cavity directly. But of course, as much that goes into the sinus cavity, goes into their bones and everywhere else, and there's side effects long term, so they can't do it that way. And now this is where we take a different approach, where we create a very big open sinus cavity. We call it a neosinus cavity. Often a draft 3 is included, and we deliver corticosteroid solutions in. And this really changed 10 years ago. When we started doing this, we really got a lot of polyp patients under control. And of course, now in 2022, we have really a fantastic additional agents in the antibody therapies to help here. Now, so we've been taking now these patients, giving them a wide, simple neosinus cavity and using corticosteroid solutions to control their condition. Now, we make it up with budesonide, betamethasone, mometasone. There's different ways in which we do it, but it's essentially about using a high volume solution. Now, why is this important? Because these eosinophilic patients need their eosinophilia controlled. The Japanese JESREC study showed us that really it's the degree of eosinophilia that predicts recurrence. And so controlling that eosinophilia is what's important. Now, we've had to rely on corticosteroids, and we now appreciate, this is my one, sort of complicated immunology slide, that in this situation here now, that there are some real players here, IL-5, 14, and IL-5, 13 and 4, I should say, TSLP, IL-25 and 33. These are major features. I don't think IgE plays a huge role here, but it's often been a one that's been targeted. And we have now agents such as mepolizumab or benralizumab to target IL-5, dupilumab that targets IL-4 and 13. We have omalizumab here, and we have tezepelumab up here. So for TSLP, so we have some great antibody treatments for this condition. And so ECRS now, it's all about corticosteroid irrigation. Low dose oral corticosteroid patients now have essentially disappeared in Australia with the advent of biologic agents. And really it's the mepo, benra, dupilumab group that really are the big players here. And really, to me, it's a great time to be a rhinologist because we have these other agents to control part of the disease that we couldn't fix surgically. But what about non-type 2? So I showed you this categorization. What about these patients that don't respond to corticosteroids? They don't have eosinophils. Well, we have great data now to direct us here. These are the non-ECRS patients. They're right up there. They're sort of slightly older, and they often are 50 plus. There are hints that maybe suggesting they're female or slightly overweight. And I used to look after these patients and do exactly what I did for the type 2 patients. I would create a simple cavity and I'd put them on a corticosteroid irrigation. And this is what they'd look like at 3 months. I haven't made this patient better using that approach. And so quite a number of years ago, when Gretchen Oakley was with us, we said, look, we've got to do a better job at defining who is a corticosteroid sensitive patient or not. And there's been some really nice work. Justin Turner has done this as well, talking about older patients who may have this non-type 2 phenotype. But really, these are the cues. They're corticosteroid insensitive. They they can or cannot have polyps. They may be older, female, obese. But we can actually be much more scientific, because if you just take a biopsy and you look at their biopsy, if you get your pathologist to tell you a little bit about it, and this is our synoptic report that all of our patients get, they've got a really low eosinophil count. And when they have a low eosinophil count, we give these patients low-dose macrolides. And the low eosinophil patients who have diffuse disease, we get an incredibly high hit rate. So this is exactly the patient I showed you before with all that milky secretions and new polyp formation. This is them after 3 months of macrolides. It's completely gone away. And so this is an example of someone who is a macrolide responder with really a super response. And it's really picked out by looking at their tissue. So if you said to me, who is going to be a macrolide responder? They have low serum eosinophilia, low tissue eosinophilia, and they have the absence of what we call squamous metaplasia remodeling, which is really maybe a discussion for another day. So in these patients, we still do surgery for various reasons. We're going to talk about that here in a moment. But this is where we might use macrolides and simple saline irrigations to help with mucosillary clearance, but not a lot of corticosteroids. So just to wrap up here, what's important then? So if you're going to manage someone down here, you've got to get the endotype right. You need to do a type of surgery we call a Neosinus Surgery. It's not about ventilation and plumbing. So you've got to make sure your surgery is consistent with the type of disease that they have. And you've got to identify at-risk patients. So picking the endotype, you just take tissue samples. This is our synoptic report. You get the pathologist to tell you about the degree of eosinophilia. This is the easiest thing. There have been people that have tried to describe the eosinophilic group, that they get early smell loss, blood eosinophilia, lots of asthma, high recurrence. They love corticosteroids, but really just look at the tissue and you get the eosinophilia. Just tissue analysis is really easy for surgeons, and that's what we should be doing. You can use serum eosinophilia, but amazingly, actually, what predicts tissue eosinophilia is a very low level. 0.24 times 10 to the 9th cells per liter in the blood predicts tissue eosinophilia 83% with a diagnostic odds ratio of 8. So you're not even outside the normal range to predict tissue eosinophilia. So although blood eosinophilia is a good marker, it's not that sensitive, and IgE does not predict what is happening in the sinus mucosa. So having high or low IgE is not predictive, in my opinion. Now, surgery then. Surgery has to have a real role. And I tell you why. Here's a patient who's a couple of months into biologics. Their polyps are still there. Nothing's happened here. Once patients form polyps like this, the biologic agents don't make them magically disappear. This is tissue remodeling. Once this happens, no medicine will make it go away. But when we take them out now, our goal should be to create a nice, simple cavity that we can treat and manage. And I'll talk about this here in a moment. But if you look at the biologic phase 3 trials, they are amazing drugs. If you look at the mean reduction in SNOT-22 scores of the treatment arm in the various phase 3 trials, there are some that do very, very well, but the overall mean reduction is almost 30 on a SNOT 22. That's a fantastic score. But if you look at the mean reduction in polyp score, the mean reduction is barely over 1. So in patients who have polyps touching the floor of their nose, if they get a reduction of only 1 to 2, it means the polyps come off the floor. That's it. So there is always going to be a role of the surgeon to remove the tissue remodeling. And there are two other things that come up, in my opinion. You get mucus plugging. So here's a patient who's had a full FES, frontal sinus. He's been doing well for many years. And he called me and said, I've got a problem on my left-hand side. And look what he's got. He's got a giant mucus plug. You see this in the lungs. Long-standing asthma patients sometimes get funny mucus plugs in certain bronchi. And the other thing that happens is that some people lose their mucosillary clearance. So they've had good surgery and their inflammatory conditions under control, but they can't clear the mucus. And so this is a really good example as well. And in those patients, we do sort of radical surgery to prevent mucus from getting caught. So we still operate, in sinus disease, but we're not doing it for ventilation. We're doing it to sort of treat the inflammation, the mucus stasis, and the secondary infection that occurs. Our immunology colleagues, they say sinus ostial occlusion is no longer considered an important part of ECRS. We should acknowledge it. If Larry Borish says it in a publication, then we've got to take that on board as surgeons. And so for primary diffuse patients, we do an operation for topical therapy to overcome mucus stasis and plugging, overcome secondary obstructive phenomenon, and reduces tissue remodeling. And really, just my last slide here, I think identifying an at-risk patient is important. So people who come and see me who need lots of systemic corticosteroid to get symptom relief, or they have terrible lungs, or they never normalize their sinus cavity after the surgery at some point in the postoperative period, or they have a really high eosinophil level in their blood at the time of surgery, then these patients might do well with biologic therapies, even upfront or early. So in conclusion here, we need to acknowledge the pathophysiology, especially for the diffuse group, is very different. It's not an infective disease, nor it is obstructive. Ventilation plays very little role. We've got to manage it differently. We shouldn't be talking about surgery or biologics or one or the other as an isolated intervention. Surgery will get rid of polyps, but it will never control the inflammation. Biologics can control the inflammation for some people, but never remove polyps or reduce mucus trapping. And so we need to talk about an anti-inflammatory approach holistically. It might be topical, systemic, biologic, local release. And we've got to talk about restoring mucosillary dysfunction. And we've got to avoid surgery as being something that's just given to people who complain a lot. It's really, surgery should be used as a tool to achieve a treatment goal. And I think this is really important for me. And I know I've gone over 1 minute or so. So look, thank you very much. That's a really important topic, I think, for our profession to sort of get on top of. And unless we start talking about CRS differently and talk about the phenotypes rather than calling it CRS, then we're really going to struggle. Thank you.